Hello, we're glad you've joined us for this live webinar, Latest Clinical Results in Oncology Drug Management. I am Judy O'Rourke of LabRoots, and I'll be moderating this session. Today's educational webinar is presented by LabRoots, the leading scientific social networking website and provider of virtual events and webinars advancing scientific collaboration and learning. This presentation has been approved for continuing educational credits. If you want to obtain the credits, please click on the Get Your Free CME CE Credits button located in the lower left of your screen. This will take you to the continuing education page where you can select speaker, click on the CE CME button, and it will take you through the process to obtain your certification. Let's get started. You can pose questions to the speaker during the presentation while they're fresh in your mind. To do so, simply type them into the Q&A box, which will open when you click the green Q&A button at the lower left of the presentation window. We'll try to get to as many as we can, and we'll follow up if we don't have time today. To enlarge the slide window, click on the screen icon in the lower right-hand corner of the slide window. If you experience technical problems seeing or hearing the presentation, just click on the support button found at the top right of the presentation window, or report your problem by clicking on the green Q&A button at lower left. I now present today's speaker, Sal J. Salamone, PhD, founder and Chief Scientific Officer of Saladax Biomedical Incorporated, which is dedicated to the development of TDM in the field of oncology and companion diagnostics. Saladax has supported numerous clinical studies supporting the use of TDM in oncology and has become the leading force in oncology TDM. Dr. Salamone has more than 25 years' experience in the healthcare and medical device industries. Prior to founding Saladax, he was Vice President of Research and Development for Roche Diagnostics, where he was responsible for North American research and development efforts for the Laboratory Systems Division. Dr. Salamone's efforts during his 17-year tenure at Roche resulted in the launch of 7 major reagent product lines comprised of more than 70 FDA-approved products and more than 200 instrument applications. Dr. Salamone is well published in the field with more than 70 peer-reviewed publications, numerous book chapters, and he is also the holder of 42 issued U.S. patents. To learn more about Dr. Salamone, click on the still image in the right corner for more information, or go to the LabRoots site. Dr. Salamone will now begin his presentation.
Thank you. It's a pleasure to talk to all of you today. I've been involved with cancer TDM for the past 12 years or so, and there's a lot of exciting results that have recently come out, and I'd like to review them today. But before I get into the latest clinical data, I just want to give a little background on what has led to this development of clinical work. First of all, I want to say that getting the right dosage of drug is really not new. Paracelsus, who was the father of modern-day pharmacology, suggested that dose really does matter, and that was back in the 1500s. And unfortunately, the alchemists didn't agree with him, and they ran him out of town, and eventually they found him murdered outside of a city in Switzerland. It's never come to that extent with me, but sometimes when you bring up a change of medical practice, you do get a lot of flack. So the whole value proposition of dose management is nothing new. It's in TDM. This has been done for years in transplantation and anti-epileptics and things like that. We want to get the dose in the right optimal range. If it's too high, there's excessive toxicity, and if it's too low, you might think that the patient is really tolerating the drug well, but in fact, in many cases, they may be getting too low of a dose. And why is this the case? Well, the way many cancer and most cancer drugs are dosed today is it's based on body surface area, okay? And that was a formula that was developed in 1916, and it was never it was never developed to fine-tune the exposure in an individual. It was developed to know the difference when you were going from, say, a rabbit to a mouse or to a primate species, to adjust, to give some type of ballpark figure as to what the dose from different animal species would be. There was this formula in the 1950s was adapted to cancer drugs without a lot of scientific evidence, and it's really stuck. It's become an artifact of older type of research, and there's many scientific papers that show that that it is really not a good way, a good metric to get the right dose in each patient. And as I mentioned, TDM is the standard of care in transplantation and antibiotic drugs and anti-epileptic drugs. Next. And as I mentioned, there's a fair body of evidence that has shown that really this way of dosing using body surface area is really not accurate. And a lot of people have suggested that looking at the exposure of the drug would be a much better way of approaching it. This was a study done by a group in Amsterdam, and they looked at the most commonly used chemotherapy drugs, and they dosed all these patients based on body surface area. And they showed that there's a coefficient of variation generally above 30% and between 30% and up to 70%. And you know, this is one of the reasons why, you know, not everybody metabolizes the drug in the same way. And, you know, it leads to a good deal of variation. So some patients are getting too much of the drug, and some patients are getting too little of the drug. And there's many factors that influence it. You know, we hear a lot about genetics, and genetics does play a key role in the variability. You know, different genotypes can really make a profound difference in the exposure in the individual, but it's not the only reason. Males and females metabolize the drugs differently often. Older people sometimes are slower metabolizers. There's polydrug interaction, there's kidney function, there's liver function. And so you cannot predict the level of a drug or the exposure of the drug in an individual just by merely looking at a patient's genotype. And so what we like to say is that by looking at the active drug in the patient, you're looking at the phenotype, which is a combination of all the various parameters that make a difference in the drug exposure. And this is a lovely example, and just look at the left-hand figure there. Carboplatin is one of the few chemotherapy drugs that are routinely monitored or routinely titered to a exposure level. And this is the case in point. If we look at the left-hand slide here, and in the yellow highlight, oops. If you look at the y-axis has the likelihood of an event, and the x-axis has the exposure level. And if you look at the line with the triangles in it, that is response rate. And what this shows you is that at a low AUC, at 2 or 3, you're not getting very high of a response rate. And then when you bring the AUC up to about 5 to 6, you're getting an optimal response rate. And any AUC or any exposure beyond 5 or 6, you really aren't getting any more benefit. That's the first thing. The second thing is the other lines that you see are toxicity. So when you go up in exposure, you're not getting any more benefit, but you're increasing the toxicity. And this work was done by Merrill, Gorin, and Jarrell back in the 1990s. And they identified really what I would call this sweet spot, where between 5 and 6, where the drug concentration should be tighter too. And it's been the standard of care in cancer research or in cancer treatment today. That's when a patient goes on carboplatin, the doctors will measure the creatinine clearance and adjust the dose of the drug based on creatinine clearance. And the creatinine clearance is a very good metric for the exposure. And so this is a good example of how TDM does work in oncology, and but for the most part, other oncology drugs aren't addressed in this manner. Okay, so that's the introduction. Now I'd like to get into some studies that have recently been done, and I'll just give a little background on this. First of all, 5-fluorouracil. It's really the base drug that's used in treatment of colorectal cancer, and it's part of the regimen for FOLFIRI, FOLFOX, and FOLFOX with biologicals. And this was a study that was done in the U.S. on 357 patients. And there's been a lot of work done to show that the target level, the proper target level for 5-fluorouracil has an AUC value of 20 to 30. And as you can see in the study, that a large percentage of patients, in fact, the majority of patients, were below the target range between 4 and 19 AUC units. And about 10 to 15% of the patients were above. And this is not the first study that has shown this. With 5-fluorouracil treatment in colorectal cancer, the majority of patients are really being given suboptimal doses, albeit there are patients that are also given high doses. And this is an early study that was published in 2008. It was by Eric Gamelin. It appeared in the Journal of Clinical Oncology. It was a randomized study where Arm A, people received the drug dose based on body surface area, and in Arm B, it was TDM, PK-guided dosing. Okay, and I use TDM and PK-guided dosing interchangeably. Okay, and if you look at this, this is a snapshot at 3 months into the treatment. Y-axis is number of patients, x-axis is the dose that was given in order to achieve the target level. So in Arm A, of course, they had traditional dosing, and all the patients were receiving 1,500 milligrams per meter squared. But look at Arm B, okay, where the patients had their doses adjusted according to their exposure. You could see that the majority of patients, okay, had dose changes in order to achieve the target level. In fact, 85% of the patients received dose modifications to achieve the target level. Next slide. This is another study that was done. Oh no, this is out of the same study. So what did all this dose adjustment mean for Arm B? Well, first of all, the toxicity was reduced considerably, and it was statistically significant. It went from 18% down to 4%, diarrhea, and hematologic toxicity decreased, as well as mucositis. And what was really quite nice is that the response rate came almost doubled. In the PK-guided dosing arm, it was 34%. Also, overall survival at 2 years went from 13% in the conventional arm to 28% in the dose adjustment arm. Now, this was a nice study, but there was a lot of criticism on it because it wasn't with a currently used regimen, especially a regimen that would be used in the U.S. A later study came out on FOLFOX6, which is one of the most commonly used regimens. And the same type of data was seen. First of all, about 50% of the patients needed dose increases, and about 30% of the patients needed dose decreases. Toxicity was reduced, as you can see. This was not a randomized study, but there was a parallel arm, by the way, and that was the blue, the BSA dosed arm. It was 39 patients, and the PK arm had 118 patients. But you can see from this data that there was a substantial reduction of diarrhea and mucositis, and the response rate was very, very favorable. It went from 46% in the BSA arm to 70% in the TDM arm. And it also, the progression-free survival went from 10 months to 16 months, and overall survival went to 28 months. So this was further proof that by doing TDM, not only were you able to reduce toxicity, but because of the higher dose intensity for those patients that were initially getting a lower exposure, the higher dose intensity resulted in better efficacy. Another study that came out, this was a US-based study. Waqif El-Diri was the principal investigator on this, and it was only done with a small portion of patients versus historical controls, but it was stage 2, 3 colorectal cancer and stage 4. And what I wanted to point out here is that this was in the adjuvant area, and we were looking at disease-free survival. And if we look at the right-hand graph there, or right-hand figure, you can see that the disease-free survival over a 36-month period was considerably better, and it was statistically significant in the PK-guided arm versus the BSA arm. This next study is 5-fluorouracil study that was done in Germany in a community setting. This was and what happened, it was an 7-center study, and it was done with 80 metastatic colorectal cancer patients, and they looked at the exposure and dose adjustment in the most commonly used regimens in Germany, and that is the AIO regimen, the FOLFOX regimen, and the FOLFOX6 regimen. The dose adjustment algorithm that was used was published by Caldate in the Oncologist about 3 years ago. And again, the target range was 20 to 30 milligrams hours per liter. That's the AUC designation. And depending on how close you were to the target range, the dose was adjusted accordingly. If you were above the target range of 30 to 34, it was a 10% adjustment. If you were above a target range of 40, it was the dose was adjusted down by 30%. On the other hand, if you were below the target range, the dose was adjusted anywhere between 10% and 25%. So, as I mentioned, there were actually 77 patients enrolled, and 16 were treated with the AIO regimen. 26 were with the FOLFOX6 regimen, and the FOLFOX regimen is 33. What we wanted to see here was how the oncologists were following the dose adjustment directions. And this is a correlation curve between the suggested dose and actual dose. And actually the correlation was quite good. When we asked the doctor to increase the dose, 77% 77% of them adjusted it in the right direction in using the suggested algorithm. No change, 94% followed the protocol, and when we asked them to decrease those, 70% followed the protocol exactly. So that's pretty good compliance, and that's one of the concerns with doing TDM, is to ensure that you know, that the oncologist is complying with the dose adjustment algorithm. And these are the results of, these are all the patients. This is a dot plot on this. And again, in this study, 64% of the patients were underdosed at the beginning, at the first dose. 33% were at the target level, and about 3% were above the target level. Primary endpoint of this study was to see if by cycle 3 and 4 that the patients were able to achieve target level. And we did achieve the primary endpoint. You can see by cycles 3 and 4, after repeated dose adjustments, the majority of patients were, and the average patients were in the target range. Let's look at cycle 3, okay? So at cycle 3, the mean AUC was 23, and standard deviation was 6. And 65% of the patients were in the target range, and 16 or 25% were below, and 10% were above. So by doing this, using this dose adjustment algorithm, we were able to put more patients into the target range by cycles 2 and 3. And the way this is done, and I should have said this from the beginning, the way this is done is that a patient is given an initial dose of 5 FU according to body surface area, and the a sample is taken any time after 18 hours after the beginning of the infusion, and an AUC is calculated. And the next time the patient comes in for, say, their second cycle or third cycle, the doctor adjusts the dose according to the previous exposure. This is just a reflection at cycle 4 of the distribution of doses needed to achieve the target range. And this is very similar to the data that I showed you from the Gamelin study in 2008. There's a wide range of dosing or dose intensity needed to achieve the target level, and this shows you the distribution. In terms of toxicity, and that was a secondary endpoint in this study, even though we had an increase of dose intensity, there were some patients that were above dose that had to be given a lower dose. And compared to historical controls, there was reduction of toxicity, the toxicity related to 5-FU, mainly mucositis, nausea, and diarrhea. So not only were we able to get the drug exposure in the right ranges, but we were also able to show that we were reducing toxicity. Another parameter that we looked at was tumor markers, and you know, oncologists often use tumor markers to just assess whether the chemotherapy is working. If they see an increase in tumor markers, they may change the regimen or change the dosing. And in this case, what I want to point out is that in about 84% of cases, the patients either had a decrease in tumor antigen level or tumor antigen level was stable, both for CA19-9 and CEA. And so the control of the disease was, you know, upwards of 80%, possibly 84%, and this is consistent with other dose adjustment studies that we've seen where they've done radiology to check out the, or they did the imaging to check out the response rate. So in conclusion, from this study, the primary endpoint was achieved after 4 cycles, and the PK-guided dosing resulted in really significantly more patients falling within the target range. We were able to reduce toxicity, and again, we showed in this study, as in previous studies, that the majority of patients getting colorectal cancer treatment with 5-FU, the majority of them get suboptimal dosing based on just body surface area. And further, this was this study was done in a outpatient community clinic type of practice, and it demonstrated that you could do dose adjustment in a community setting and get significant results. Okay, I want to switch now to Paclitaxel. We just, this was a study also sponsored by Saladax, as well as the CESAR organization in Austria, and it was an investigator-led study. Paclitaxel pharmacology, again, the variability of exposure of paclitaxel when you dose based on body surface area is quite large. And a number of investigators over the years have shown that the critical PK parameter is time above threshold. Okay, and the threshold concentration is 0.05 micromolar. A target range for the optimal time above threshold is 26 to 31 hours, meaning that a patient's blood level should be of 0.05 micromolar should be at that level between 26 and 31 hours. If it's above 31 hours, there's more toxicity, and if it's below 26 hours, there's a lack of efficacy. And that blood level was based on hematologic toxicity. There have been limited sampling models generated. This was done by Marcus Jorga, who's a leader in this field of Paclitaxel Pharmacology. And what you do is you take one sample between 18 and 30 hours, and you can calculate the time above threshold. Now, major toxicities, and the 2 major toxicities with paclitaxel that one has to be aware of is neutropenia and also neurotoxicity. Now, oncologists tell me that the neutropenia is something that they can deal with because there's cell-stimulating factors that if somebody is suffering neutropenia, they can be given growth factors, and that will help stabilize them. The toxicity that a lot of oncologists are very concerned with is the neurotoxicity. There are no drugs available to prevent it, and there are limited treatments available to try to mitigate the effects of neurotoxicity. And it appears quite often, and it can last far beyond the treatment cycles. This was a randomized 2-arm study. The patients that we looked at were non-small cell lung cancer patients. It was 3 weekly paclitaxel with carboplatin, and of course carboplatin was titrated to an AUC. Arm A had conventional dosing, and Arm B had a TDM or PK-guided dosing. The target range was between 26 and 31 hours. The primary endpoint was reduction of neutropenia and Secondary endpoints were neuropathy and tumor response, progression-free survival, and overall survival. This is how the randomization occurred. Again, there were altogether 386 patients in the study. As a matter of fact, this is the largest PK-guided dosing study ever done in the field of oncology. Okay, there were only two others ever reported, one from methotrexate back in 1998, and the 5-fluorouracil one by Gamelin in 2008. Okay, so this is the dose adjustment algorithm, and I just want you to focus on the top part for the first glance. If you look, before, in the PK-guided arm, patients had their dose adjusted initially based on age and gender. So if a female would receive a lower dose than a male, because females are known to metabolize it more slowly, and an older patient metabolizes it more slowly. So there was an initial dose adjustment based on these two parameters. And then in the end, if you look at the lower right-hand box, there was a dose adjustment chart based on the levels that they had, and in every cycle they were adjusted accordingly. This is the distribution of paclitaxel dosing, okay? So if we look at the conventional arm is green, and the PK arm is red, and that orange arm is the initial pharmacology dose adjustment based on age and gender. And so what you could see is that the starting dose of this, in the conventional arm, the median starting dose was 200 milligrams per meter squared, and that's the conventional way of dosing it. And the median dosing in the PK-guided arm was 170. And then if we go all the way to cycle 6, what you can see here is that in the conventional arm, people stayed at that initial dose of 200. Actually, the median was 198. But in the PK-guided arm, in order to achieve the target level, the median was 133. And then take a look at the distribution of the doses that were needed in order to achieve the target level. And again, this is a reflection of the PK variability, normal PK variability that one sees, that each patient really had to have a unique dose in order to achieve their target level. And so what we see is that over the course of the study, there was about a 30% lower dose intensity in the PK arm. Now remember, when I showed you 5-fluorouracil, the majority of patients seemed to be getting too low of a dose. With paclitaxel treatment in non-small cell lung cancer, it seems that more patients are getting too high of a dose. This is just whether what PK-guided dosing and what percentage of patients. If we look at the PK-guided arm in this table, you see that 62% of the patients needed dose adjustment downward, and 18% of the patients needed the dose adjustment to be increased. So while the majority of patients were getting too high of a dose, there were some patients that were getting underdosed. And this is a distribution in the PK-guided arm. The shaded area in this figure is the target area. And what you can see is that there were a great deal of patients above the target area and also a substantial amount below. And by doing PK-guided dosing in each subsequent cycle, you could see that we were able to really get most of the patients below the below the highest target level. And that was the aim of the study. And what else can I show? And each point represents the patient. And the reason why we have less patients by cycle 6 is that this is non-small cell lung cancer, and there was many of the patients deceased before the end of the cycle or dropped out of treatment. Now, what did all this dose adjustment do in terms of toxicity? Well, the primary endpoint of neutropenia wasn't achieved. There was a reduction in neutropenia, but it was leaning towards significance, but it wasn't significant. There was a 16% reduction. But what was significant, and this was very surprising, was that there was a 39% reduction, and it was statistically significant, of grade 2 or higher toxicity, and a 78% reduction of grade 3 neuropathy. And so this was very nice to see, that because as I mentioned earlier, the neuropathy is a very difficult toxicity to deal with. And by doing this dose adjustment, you can substantially reduce this type of toxicity. That's fine to reduce the toxicity because you are lowering the dose intensity, but the question is, by lowering this toxicity, by lowering the dose intensity, what happens to outcomes? And if we look at the response rate, there was really no difference between stable disease or complete or partial response. There was some difference, but it wasn't statistically significant for response rates. And then progression-free survival between the two arms was very similar. You can see that in the left-hand graph. And overall survival, again, was very similar between arms. So what we have here in the conclusions is that PK-guided dosing did result in a clinically relevant reduction of neuropathy compared with standard dosing, and that the lower dose intensity of about 30% did not significantly change the efficacy. And this is the first time that this type of work has been shown with paclitaxel. And again, the reduction of neuropathy is pretty significant. And the last study that I wanted to talk about is a similar study to what I just showed you from Germany, but this one is being done in Shanghai at Shanghai Pulmonary Hospital. Again, it's a randomized treatment. These are interim results. They were presented at ASCO in June, and the results are very similar. So this is the second such study using paclitaxel and carboplatin and looking at toxicity as the major endpoint. So far, this study is supposed to accrue 300 patients. Thus far, it's accrued 155 patients. And in this study, we looked at the exposure both in the BSA arm and the PK-guided dose adjustment arm. And again, the red is the conventional dosing, and the green is the PK-guided dosing. Here, in this study, there was no initial pharmacology adjustment for gender or age. And so if you look at the green and the red, you'll see in cycle 1 that they had very similar exposure. And most of the exposure was above the target range. And then this was a 4-cycle treatment. And as you can see, in the PK-guided arm, patients had lower and lower dose exposure as each cycle went on. Okay. Now, what did this mean in terms of toxicity? And again, what we're seeing is a reduction, not clinically significant, of neutropenia, but we are seeing a trend very similar to the CEPAC study that I just went over, with lower reduction of neuropathy greater than grade 1, greater than grade, and a 43% reduction in greater than grade 2 neuropathy. This is very, very early data, but the trends are the same, and and what this is doing is validating that dose adjustment algorithm is actually being effective, and it's able to reduce toxicity. We have some data on response, not progression-free survival or overall survival, but we have some imaging data, again, showing that with all of this dose reduction in the dose adjustment arm, there is no difference in response rate. So the conclusion of this study, again, this is just interim analysis, so we don't have statistical significance here, but this verified what the CEPAC study has also shown, that there's wide variability in exposure when you're being dosed based on body surface area. The dose algorithm was effective in modifying the exposure, and the overall dose intensity was reduced between 20 and 30%. And it seemed, and again, similar to the CEPAC study, there was a lower incidence of toxicities without reducing the efficacy. This study should be finished, I would say, in another 3 or 4 months. And that's really all I had to say, and I'll take questions at this stage.
Thank you, Dr. Salamone, for your presentation. A quick reminder for our audience on how to submit questions. Simply type them in the Q&A box found by clicking on the green Q&A button at the lower left of the presentation window. We'll try to get to as many as we can, and we'll follow up if we don't have time today. And your first question is, could you mention again, what are the parameters for PK-based dosing?
What are the parameters for PK-based dosing? I'm not quite clear. On the question, but let me go through. For 5-fluorouracil, it's called area under the curve, AUC, and what area under the curve is milligrams per hour, or milligrams times hours per liter. And so that's, what the critical PK parameter is. In terms of paclitaxel, it's not AUC, but it's time above a certain threshold, a certain concentration threshold. And in the case of paclitaxel, it was 26 to 31 hours. Did I answer the question properly?
I would say that you did, definitely.
All right. Well, maybe there'll be a follow-up question. Okay. All right.
Sure. I just want to remind people again how to submit questions. So you type them in the Q&A box, which is found by clicking on the green Q&A button located at the lower left of the presentation window. And so a message of thanks has come in from one of the listeners. So if there are no more questions, I would once again like to thank you, Dr. Salamone, for your presentation. Do you have any final comments to share with us today?
No, I just hope I gave the audience a view about the necessity that really, if somebody's being treated with chemotherapy agents, that, current methods just are not very good. And really exposure is an extremely important aspect. And, you know, we hear so much about personalized medicine, and doing TDM in oncology is really a very significant step towards personalizing dose on a patient-by-patient basis. And thanks for your attention.
Oh, a question has come in now. I hope you have a moment to answer it. Okay, so
sure.
How do you find documents, let's see, how do you find documents where chemotherapy regimens were written about in the AUC? I hope I stated that correctly.
You mean publications. The literature is really, the literature is full of publications showing, documenting target levels for AUC. So if you are interested in finding the publications, like go to PubMed and you know, type in 5-fluorouracil pharmacokinetics or 5-fluorouracil PK-guided dose adjustment, and you'll see that there's quite a number of articles that have come out. Just with 5-fluorouracil, there must be at least 20 or 30 studies demonstrating the variability of 5-fluorouracil. And with paclitaxel, there's probably 20 to 30 studies as well. So the pharmacology literature is really full of this type of work.
Okay, I have another one for you. How long is the duration or time point to check PK when you perform PK-based dosing?
Okay, so for 5-fluorouracil, generally the regimens go for 46 hours. And so what we like to say is you should collect between 18 hours and 42 hours. You take one point, okay? And you have to take it from the vein because the patient still is having the drug pumped into their port. And the reason why you don't collect a point closer to 46 hours is sometimes the pumps run out, and so if the pump runs out, you really can't take the sample. To get a proper value, the patient has to be undergoing infusion with 5-FU. So in short, you have to take it either the second day or 4 hours before the end of infusion on the third day. With paclitaxel, they get a 3-hour push of the drug in the beginning, and then they have to come back the next day, and anywhere between 18 hours and 30 hours, they need to have a sample taken. And so these limited sampling strategies have been developed, and they've been shown to be a very effective way of estimating the exposure in the patient.
Okay, well, thank you again, Dr. Salamone, and I'd like to thank the audience for joining us today and for their interesting questions. Just a reminder, if you wish to obtain credits for today's session, please click on the Get Your Free CME CE Credits button located in the lower left of your screen. This will take you to the Continuing Education page where you can select a speaker, click on the CE CME button, and be guided through the process to obtain your certification. This webcast can be viewed on demand through April 1st, 2016. LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. Until next time, goodbye.